For many years, supplemental oxygen was considered a standard part of the treatment for every patient with suspected acute coronary syndrome. The assumption was simple. If the heart muscle is deprived of oxygen, giving more oxygen should improve outcomes. However, modern evidence has challenged this practice. Multiple randomized controlled trials have shown that in patients who are not hypoxic, routine oxygen therapy does not reduce mortality, recurrent myocardial infarction, or other major cardiovascular events. In fact, excess oxygen may be harmful because it causes coronary vasoconstriction, increases oxidative stress, and may actually increase myocardial injury. A large systematic review also found that liberal oxygen therapy in patients without hypoxia was associated with worse short- and long-term outcomes. The lowest mortality was observed when oxygen saturation was maintained between 94 and 96%, emphasizing that more oxygen is not always better. One of the landmark studies that changed our practice was the AVOID trial, which evaluated patients with ST elevation myocardial infarction, presenting within 12 hours of chest pain and having an oxygen saturation above 94%. This was a single-blinded, randomized controlled trial involving 470 patients across 9 hospitals. Patients were randomized to receive either 8 liters per minute of oxygen or room air, with oxygen in the control group given only if the oxygen saturation fell below 94%. The primary outcome showed no significant difference in peak troponin levels, indicating that routine oxygen therapy did not provide any clinical benefit. More importantly, several secondary outcomes suggested potential harm. The rate of recurrent myocardial infarction at discharge was significantly higher in the oxygen group, occurring in 5.5% of patients compared with only 0.9% in the room air group. Cardiac MRI performed at 6 months demonstrated a larger median infarct size, measuring 20.3 grams in the oxygen group compared with 13.1 grams in the room air group. Patients receiving oxygen also had significantly higher peak creatine kinase levels, with a mean of 1,948 units per liter, compared with 1,543 units per liter in the room air group, suggesting greater myocardial injury. Although the study was relatively small, these findings raised important concerns that routine oxygen administration in normoxic STEMI patients may actually increase infarct size rather than reduce it. These observations were confirmed by the much larger DETO2X-AMI Trial, published in the New England Journal of Medicine, by Hoffman and colleagues in 2017. This pragmatic, registry-based randomized clinical trial enrolled 6,629 adults with suspected acute myocardial infarction from 35 hospitals in Sweden, all with oxygen saturation of at least 90%. Patients received either 6 liters per minute of oxygen for 6 to 12 hours or room air alone. At 1 year, all-cause mortality was virtually identical, with 5.0% in the oxygen group and 5.1% in the room air group. There was also no reduction in recurrent myocardial infarction, no reduction in infarct size, and no improvement in peak troponin levels, confirming that routine oxygen therapy provides no benefit in normoxic patients. So, what is the message from all these trials? Oxygen is a drug, and like every drug, it should be given only when there is an indication. Current guidelines recommend against the routine use of supplemental oxygen in patients with acute coronary syndrome who have an oxygen saturation of 90% or higher. Oxygen should be administered only to patients who are hypoxic, have respiratory distress, pulmonary edema with hypoxemia, or another condition requiring supplemental oxygen. The take-home message is very simple. Treat hypoxia, not myocardial infarction, with oxygen.